Good day. My name is Jim Mckinsey, and we're here at the Transformative Endovascular Decisions Conference, and I have the privilege of being here with Dr. Christopher Zarins. Dr. Zarins has been a thought leader in vascular surgery for more years than either of us wanted to admit. I was fortunate enough to train with Dr. Zarins back at the University of Chicago and really learned to appreciate his ability to be insightful and thoughtful and really thinking forward on how we manage a lot of our complex problems. Today we're going to talk about how we really try and pre-op our patients. One of the times I have a patient coming in, and he recently had it where it seemed fine. He'd actually had a cardiac workup. They said he was in good shape. He had had a previous cardiac history, and we were going to do a fenestrated stent graft on him. Cleared him. That afternoon, post-op, he started having chest pain, and turned out he had a significant recurrent coronary stenosis and had to go for an emergent cath. How can we try and find new ways to get a better understanding for our patients, not going through all the hassles of trying to send them for cardiac clearance and then wait for a result, and sometimes you don't even get the right answer? What's new out there for that?
Well, this is a very important problem, right? Because we know all vascular patients have coronary artery disease. It could be an asymptomatic carotid. It could be the so-called simple vascular patient, but they all have coronary artery disease. And that's why traditionally we've always done cardiac clearance with things like stress tests and echocardiograms in order to have anesthesia agreed to put our patients to sleep. Well, now there's a new way to do that, and a much better way, and that's based on cardiac CT scans. Because cardiac CT scans very clearly tell you, yes, you do or you do not have coronary artery disease. But in a way, they're almost too good because they see everything. And in the vascular surgery population, most patients have severe calcific coronary disease, but you don't know if it's functionally significant. And you can now determine that with a test called fractional flow reserve, CT-based fractional flow reserve, which gives you a three-dimensional map of FFR values throughout the coronary tree, tells you whether or not you have hemodynamically significant coronary stenosis that will benefit from coronary revascularization.
You know, we've all heard about the calcium scoring for coronary disease, and I've never been really that impressed with it because, as you say, everyone has some degree of calcification in the coronary arteries. So how is this different? You were talking more about actually giving a more functional type of assessment there.
So a calcium score is just simply a CT scan without contrast. So you see the calcium, but you don't see the coronary arteries. A coronary CT scan is with intravenous contrast injection, which actually shows visualization of the coronary artery lumen plus the plaque. So you see both. You see the plaque and you also see the lumen. But the visual assessment of the stenosis is not very accurate. Just like with an angiogram. You look at an angiogram and say, gee, that looks like a really bad stenosis, but it may not be. It may not be functionally significant. So there's no benefit from revascularizing that lesion. So today, the standard of care for coronary revascularization is anatomic and functional assessment with fractional flow reserve. And you can do that non-invasively. So how is that a big advantage? Well, it's an advantage that since you don't have to go to the cath lab, you don't have to have a cardiologist to do it. So there are new guidelines. It is the 2021 American College of Cardiology, American Heart Association guidelines put cardiac CT scan plus FFRCT as a frontline diagnostic test to tell you, do you have coronary disease? And if so, is it functionally significant? And you don't need a cardiologist to do that. You as a vascular surgeon could order that test and get the results. And then if you see that there's no functional significance, you could take that to the anesthesiologist and say, look, I got my cardiac clearance.
So with that, is it showing areas that may be at risk, or is it just showing functional flow? Is there a stress component to it? How does that work?
Well, so the way the stress component in the cath lab for fractional flow reserve is adenosine. So adenosine is a coronary artery vasodilator that maximizes coronary flow. So you bring out maximum flow across a stenosis, and if there's a pressure drop, it's just like an exercise test and looking at your ankle brachial index to see if it drops with exercise. You do the same in the coronaries with the fractional flow reserve. With the computational analysis of fractional flow reserve, you do that computationally. So you simulate maximum hyperemia by dropping the peripheral resistance in the flow formula, and that then gives you a fractional flow reserve, non-invasively called CT-derived fractional flow reserve. That's now FDA approved. It's available in hospitals. It's reimbursed by insurance, reimbursed by Medicare, both on inpatient and outpatient basis. So you as a vascular surgeon could order that test and determine for yourself, is this patient fit for surgery or not? And the patient you described could have had a test beforehand. And if you could have identified severe disease, you could have made a decision. Does this patient need preoperative coronary revasc? Or maybe not. Maybe he needs postoperative coronary revascularization.
Okay. So in some of our patients, they actually have previous infarcts and scar tissue in part of their myocardium. How does this interpret that area of scar tissue?
Well, it's the same as if you measured it in the cath lab with a fractional flow reserve. So if you've got previous scar tissue, that coronary artery narrows down and it supplies less of the heart. The collaterals take over, and the computation, either the direct measurement of fractional flow reserve or the computation of fractional flow reserve, is not affected by previous scars and myocardial infarctions.
So it's like a stress test that we do normally. You see, can this area be enhanced or not? And in those areas of scar, it really doesn't show that it has any uptake or more uptake once you've stimulated it.
Yeah, but it's different from a stress test because a stress test gives you global ischemia. It tells you nothing about the coronary arteries themselves. And stress tests are notoriously inaccurate. They're about 50% accurate. So you can miss real lesions, and you can call diagnostic real lesions that are not really there. But this gives you a coronary specific test, not a global myocardial ischemia test. And that tells you specifically, is that coronary lesion significant? Couldn't you put in a stent? Maybe it needs a bypass. But you have now specific information on which to make a decision. This patient, yes, does need to go to the cath lab for a coronary angiogram, where this patient does not. And that's where it gives you the power to now control the referral pattern.
Right.
You can send this patient to that cardiologist for a coronary angiogram, or you can send him to the other one. So you have control of the patient flow and an upstream diagnostic test for your patients.
So really what you're creating is you're an individual artery, so you're not counting on global perfusion, and you're giving a roadmap to the cardiologist saying, we've now identified these lesions, can you fix them? So you're really controlling the flow of the patient then.
Exactly, and even more, if a patient has severe three-vessel complex disease with left main disease, maybe that patient goes straight to the cardiac surgeon for a coronary bypass. So maybe they don't need a stent, they need a bypass. And in fact, there's a randomized trial ongoing now where cardiac surgeons are doing and planning coronary revascularization, coronary bypass procedures on the basis of FFRCT alone, not on the basis of coronary angiography.
So they don't need another invasive test. They can go straight from being evaluated by your process and straight to having surgery.
Yeah, but that's now still in the investigative stage.
Okay.
Yeah.
Okay. You know, how hard is it to get? What's the turnaround time in getting the study done and the report back to you?
Well, that's a good question. So it requires getting a cardiac CT scan. And the CT scan is then done by either a CT cardiologist or a CT radiologist, depending on which hospital you're in. And then that CT data set is uploaded through Amazon Web Services to the HeartFlow computers, then to calculate the fractional flow reserve and return a three-dimensional model of FFR values within 2 hours. That now then can be read and interpreted, and decisions can be made on how best to treat that patient.
So to get an FFRCT, do you need any special protocols to pre-order the scan, or can they take any coronary angiogram?
Well, it requires a high quality CT scan. And it requires two things. It needs a heart rate control to slow the heart rate, which gives you a higher fidelity and better quality CT image. And second, it needs nitroglycerin to dilate the coronary arteries. That's what's done in the cath lab to dilate the coronaries to bring out the pressure gradient across the lesion. And in the CT scan, you also give sublingual nitrates just before you do the CT scan.
And you have a protocol that we can send if for our cardiac CT scan, say, this is what we want to have because we want to get this later analysis?
It's the standard protocol.
Okay.
It already exists. Every quality place that does coronary CTs follows the same protocol, so it's already there. You don't have to do anything.
Great. So how many centers are using this, and how do you see expanding this concept? Because it sounds really revolutionary to get, so now we can get the answer and not have to have sending them to a cardiologist, sending them, waiting for the stress test, them not getting them in the office hours, and then weeks of delay in trying to treat our patients.
Well, this is just barely getting to be recognized. A couple of weeks ago here in Scottsdale at the Southern Association for Vascular Surgery meeting here in Scottsdale, we presented study results from Latvia of 522 patients undergoing carotid, peripheral, or aneurysm surgery, divided into two groups. One group got cardiac CT and FFRCT, the other group did not. The standard of care is don't do the testing. That's how we were doing it right now. And the results then at 5-year analysis is you can cut the mortality rate of those vascular surgery patients in half. Why? Because you diagnosed and treated the coronary disease. So the patients who had positive FFR values were then sent for coronary angiography and coronary revascularization. So it's no surprise if you have left main disease, proximal LA disease, and you diagnose and treat it, you won't die of your heart disease. And that's the primary cause of death of vascular surgery patients.
So if say you have a 68-year-old man who has a history of smoking and borderline diabetic, should they get the scan?
Yes. Even higher risk is the 50-year-old man with a SFA occlusion. He has no symptoms. He just complains of his claudication.
Right.
But he very well may have left main disease and proximal LAD disease. And the important thing to know that if you ask any cardiologist this question, is it true that 50% of all patients who come into the hospital with an acute MI or drop dead of a sudden cardiac death, they have had no previous cardiac symptoms? So the primary indicator of coronary disease is a heart attack or death. And cardiologists will say, yeah, that's true. And I say, well, don't you worry about that? Don't you want to test these asymptomatic patients and find out if they have left main disease? And when they do the studies, yeah, 8% of those patients have it.
8%?
Yeah, in the ischemia trial, 10,000 patients, 8% have it. Right, so it's out there, and it's asymptomatic, and people are dying. But that doesn't mean you go and study everybody. I mean, that's not practical. But the highest risk patients are the vascular surgery patients. They've already identified themselves as having atherosclerosis. Asymptomatic carotids, they've got coronary disease. Claudicants, aneurysm patients. Only 1% of deaths for aneurysm patients is due to aneurysm-related causes. We just heard a paper here on asymptomatic carotid stenosis, and everybody talks about the risk of stroke. The long-term risk of death is 3 or 4 times higher than the risk of stroke or stroke death. Nobody talks about the mortality. It's time for vascular surgeons to become cognizant of the fact that, hey, vascular patients have coronary disease, and we need to take a part in diagnosing and treating them.
Yeah, I think that's an exceptionally good point, and that, if I look back at my patients, is that over every 10 years, it seems like significant component have died, but not because of vascular disease, but because of coronary disease. So I think trying to detect that is really something we need to consider more as a service for our patients, since they've already proven they have a potential coronary disease.
You're exactly right. And what's even more remarkable, over the last 40 years, we have seen absolutely remarkable changes in the improvement in the diagnostic and treatment of vascular disease. We see that here in the TED conference, right? But over the last 40 years, there's been no change in the mortality rate for cardiac disease, for vascular patients.
Right.
During that same 40-year time period, the mortality for coronary disease patients has dropped remarkably. Why? Because they diagnose and treat the coronaries.
Yeah, I think that's certainly something. As we look at all-cause mortality, we say, well, there's nothing we can do about that. Vascular mortality, we're fixing that and getting better and better. But you're right, we're still losing a lot of our patients for this undiagnosed killer. So, well, I think that's been an exceptional overview of kind of the new technology come out. I thank you, Dr. Zarins. It's always a pleasure to work with you, and hope you enjoy the rest of the conference.
Thank you very much.
Take care.